Patricia, I think we can start. It's 12:05.
Dr. Cowan,
Okay, sorry,
you
I
ready?
couldn't mute myself.
Okay, let me introduce. Okay, so welcome everybody. Today I have the pleasure of introducing our speakers, Dr. Gerd Pust, Associate Professor of Surgery and Trauma, and Dr. Jane Cowan, a Critical Care Fellow from Ryder Trauma Center, Jackson Health System, Miami. Dr. Pust and Dr. Cowan, thank you so much for accepting our invitation. Are you ready?
Yes.
Okay.
So as she said, I'm Jane Cowan. Dr. Pust and I had this case together some weeks ago. Let me begin. So the brief history for our patient was a 29-year-old male who presented with a gunshot wound to his left lower back. Importantly, he had a gunshot wound to the chest and abdomen, multiple gunshot wounds, status post an XLAP that was complicated by SBO requiring multiple subsequent XLAPs 12 years ago at our same institution. And we had the records, and the attending was still on staff who had done it. So we knew both from his physical exam and from that, sort of a baseline of where his abdomen would be. On primary survey, his airway was patent. He had bilateral breath sounds. His heart rate was tachycardic in the low 100s. His systolic blood pressures were normal in the 140s, and he had palpable distal pulses. His GCS was 15, but he had, we could not elicit any motor from his bilateral lower extremities. He did appear to have sensation intact bilaterally, but complained of severe neuropathic sounding pain to both legs from the hip down. So we exposed him, and we found a single aperture to the left of the spine at the low thoracic, high lumbar level. Again, he had a well-healed midline laparotomy scar. We did not perform a FAST. We performed a chest X-ray, a KUB, and then a lateral pelvis, which I will show now. So it may be hard to appreciate on these small screens. I don't know if anyone has a big screen, but there is some ballistic material here. And then this pelvis is not the best, but the abdomen, can you see my arrow?
Dr. Cowan, just one suggestion. Maybe you could hit play and make it a presentation mode on top so that it might help a little bit.
Yes.
Perfect.
Okay.
Yes. Thank you, Maya.
Oh, you're welcome.
Now I cannot see my cursor. Can you see my cursor?
Mm-hmm.
I can't.
Yes, I can.
Okay, well, I can't see. So in any case, so the pelvis here, you can see the curve of the abdomen and then the thigh coming here. So this is low pelvis. And then on the KUB, you can see a retained bullet. Our first branch point.
Thank you, Dr. Cowan. Dr. Hodgman, can you hear me?
Okay.
Do you have any consideration to make?
Yeah, no, at this time, you have a patient with this patient, most likely than not, he would need to go to the operating room. Usually gunshot wounds that go into the abdomen, you go straight to the operating room. Having said that, this guy has multiple surgeries. You're going to have a very hostile abdomen. He is hemodynamically stable, and he appears to have a spine injury, which will complicate everything. In spine injury, anterior spine injury, we also be worried about a vascular injury, either the aorta or the IVC. So if the patient is hemodynamically stable, I think at this time, I would probably get a CT of the abdomen to get a better idea of what's going on. and plan the approach, because this is not going to be a straightforward midline laparotomy and go and find and solve whatever you find there. I think that this might require a more complex approach before proceeding with surgery. If the patient becomes hemodynamically unstable, he needs to go to the operating room for a laparotomy. Thank you.
Thank you, Dr. Hodgman. Dr. Kasim, could you please share your experience at this time? Dr. Kasim? Dr. Antrak?
Yes, so I agree entirely with Dr. Hockman. I really don't have anything else to add. He's hemodynamically stable. There's the enigma of the motor deficit to the legs with spared sensation, and the bullet went just to the left of the spine, so you would expect it would be in the trajectory of the aorta. May have passed anterior to the spine and caused a shock wave interfering with the anterior cord. So I agree with going to CT in this case.
Thank you, Dr. Antrak. Dr. Epstein, any comment?
Same thing. I would take him to CT. As Dr. Untrak said, he probably has a spinal cord contusion. And it would be nice to see exactly the path if it's possible. But he's going to the operating room. It looks like it's passed anteriorly on the lateral pelvis, but CT would show that.
Thank you, Dr. Epstein. Dr. Lenin, can you hear me? Would you like to be a panelist today?
Sure. Yeah, I mean, I wouldn't do anything differently.
I can't hear you.
Can you hear me?
Yes, absolutely. Thank you.
Yeah, I mean, I would probably just take him to the operating room at this point.
Okay. Thank you, Dr. Lenin. Dr. Rivaturi, any comments?
Yeah, I agree with everything that has been said, but this is one time where you have a gunshot wound to the abdomen that doesn't have to go to the operating room right away, but we'll get a lot of information from the CT. Since you already gave us the topic of migratory bullets, can you tell us what the pulses in the distal extremities are? All the pulses are palpable in all the extremities?
Yeah.
Okay, thank you.
Thank you, Dr. Rivaturi. Dr. Kassim, can you hear me? Okay. Dr. Cowan, your turn, please.
So
Can I make a quick comment? As Dr. Pust, can I make a quick comment regarding the CT scan? Typically, when we know that there's a bullet in the abdomen, there's no reason really to do a CT scan, right? As already mentioned, the patient needs to go to the operating room. He actually came in during the night, and the night team who was on before us, they were thinking, well, abdomen could be from his prior gunshot wounds. And they wanted to confirm, since, you know, as you already mentioned, there's going to be a lot of adhesion, it's going to be a hostile abdomen, that maybe, you know, it could be just a spinal cord injury, and the projectile at this time did not go into the peritoneal cavity. And the projectile you see on the x-rays might have been from his previous gunshot wounds 10 years ago. That was their thinking, why they decided to do a CT scan since the patient was stable. However, he has a spinal cord injury, so his physical abdominal examination is not really reliable. So I think no matter what, you're going to end up having to explore him. So I'm not sure if the CT scan is really going to add a lot of information. You'll know a little more what to look for when you're.
Dr. Cowan, this is Dr. Ruiz. I have a request. Can you bring back the x-rays again?
Yes.
So the one on the right-hand side is a cross-stable lateral, right? Let me see if I can see it better. Okay, and then you have, I see a ballistic fragment that is anterior to the anterior surface of the vertebral bodies, if I'm not mistaken. Is that right?
That is correct.
Yeah, so in that case, I would probably just go to the operating room without going to CT scan. I know there's a lot of confounding factors here, but I would be concerned sending this patient to the CT scan, knowing that he has an intraperitoneal injury or at least a retroperitoneal injury in that situation.
Thank you, Dr. Reese. Dr. Cowan, your turn, please.
Okay, so at first it was unanimous, and it was not unanimous, but as Dr. Pust already alluded to, he did go to the CAT scanner for the concerns he mentioned. And let us see if these videos will play. The first, the axial. If anyone's noticing suture material in the abdomen, he had a small bowel resection and an extended right colectomy previously. I'll replay it. There was the bullet. So we marked the aperture with a paperclip here.
Jane, did you say he had an old retained bullet?
I did not say that.
Okay, so he had no retained bullet.
You're spoiling my surprises, Dr. Proctor.
Oh, okay.
It's not fair.
And then here is a coronal.
Hey, don't put the TV on.
I'll replay it again. Lastly, I have a sagittal from right to left. And then since we're concerned about a spinal injury, I have one on bone window through the area of concern. Here's the paperclip. And then I thought perhaps before I discuss the findings on the CT, to see if the panelists had any thoughts, and then we can go through the radiology reads.
Thank you, Dr. Cowan. Dr. Epstein, would you do something different?
No, I would do exactly that. But maybe my eyes are old, even though I'm wearing glasses. I don't see any bullet scatter on any of these CTs. Am I missing something?
It's in the pelvis. I'll replay the axials right now. So it was determined that the wound was at the L1 level. And then if you see bullet here in the pelvis.
Is that the pelvis on the other side from the entrance wound?
It is. It's on the right.
Well, I would have stopped, I think the idea of the CT is perfect. What the reads are, we'll find out.
Anybody have any comments before I go through the reads?
Yes.
I have a question. It's difficult. The windows are difficult to see, at least in this. But I don't see a fracture. Maybe I'm missing something. I thought I saw a bubble of air in the spinal canal, but this is a very high injury to the spine. This is T12 because essentially he has no mobility in the lower extremity, the L1. But I don't see a big fracture there, so I cannot explain why he has the motor deficit. And this appears to be all retroperitoneal, but I don't see too many injuries retroperitoneal. So I really, I don't know. There is something that doesn't add up here. Sorry.
Thank you, Dr. Hodgman. Dr. Cowan, can you answer?
There's a hand up.
I think Dr. Antrek wants to make a comment. Yes, Dr. Antrek.
Okay.
Yeah, so that large density in the pelvis is that you pointed out the bullet, but it's a very large density. It's larger than you would expect from a bullet fragment. But in any event, I didn't see anything that looked like a pneumoperitoneum. And also in the right upper quadrant around the hepatorenal pouch, Morrison's pouch, it looked like there was a collection of fluid there. It went by quickly, but I thought I saw an abnormal density in the right upper quadrant. I don't know if you can go back to that.
Yeah. So let me go through them now with our retrospective eyes. Now that we discussed it with the radiologist and we operated on them. So just as you said, as you go through the axials. The reason I did a bone window is that the fracture is very subtle, so we'll go back through that as well. So there was fluid here. I think it's easiest to appreciate on the coronals here. So as we come up through here, anterior to the psoas, we have fluid here around the duodenum. Let me replay it. And we have some specks of air. But you're right, there's fluid here in the hepatorenal recess. Let me go to the next scans. So you can see the fluid layering here. And then I don't know whether it's my images that are difficult. I long for the big radiology screens that are so high definition, but let me try to show you where the fracture is on the spine, on the bone window. So here. One more time. Here. Any comments now before I proceed?
Let me ask Dr. Lenin, do you have any comments? Dr. Lenin,
everything was in the morning report.
Yeah, I'm not sure. At this point, I would probably go to the operating room.
Okay. Thank you, Dr. Lenin. Dr. Ivaturi, any comments?
Yeah, I couldn't really make out.
Okay.
Sir, we can't hear you.
Yeah, I can hear you. Dr. Ivaturi?
I think you've muted yourself.
Yeah. Dr. Ivaturi, are you muted? Okay. Dr. Kassin, can you hear me? Dr. Proctor, any comment?
Oh, ma'am, I'm just listening.
Okay. Dr. Ruiz, any comment?
Yeah, so I did see the fracture very subtle. I don't see penetration into the spinal canal. But my question is, since this patient is a patient that was in our system, if I got this right from the presentation, was there any chance or any attempt to look at previous films from his previous stay? Sometimes we get these patients with repeated penetrating trauma, and we have to go back, find the x-rays, and compare bullets on previous x-rays, and that's how kind of we know. If we don't have any previous x-rays, with the images that you have, this patient belongs in the operating room at this point?
So we were able to, it takes a moment to get him from his NATO trauma name to his legal name, but we were able to look at his old op reports and his old x-rays, and indeed the bullet fragment in the pelvis is new. And then, as I said before, just to reiterate, he had had a previous exploratory laparotomy, and subsequently, after a small bowel obstruction, had an extended right colectomy and a small bowel resection.
All right, then my recommendation is to get some backup to cover for the rest of the night, because you're going to be doing a long case.
Well, we took him in the morning.
So can I make a comment? It's very interesting you're saying that, Gabe, because what happened is the night trauma team was doing another case, and they did not call in the backup because they felt like this patient is stable and can go afterwards. And that alone is a reason for discussion, because there was a significant delay from the time of arrival until this patient went to the operating room, because we took him in the OR when we came in the morning, and he arrived about 2 a.m. So there's like almost a 5-hour delay to go for surgery. So I agree with you. In fact, the second team should have been called in and take this patient to the operating room earlier. Even so you're stable, you don't want to have somebody with potential bowel injury sitting there for hours. And the CT scan is, at least concerning, if not consistent, with a duodenal injury, because there's fluid next to the duodenum, there's air bubbles next to the duodenum, and it's within the proximity of the trajectory of the bullet. So, there was a significant delay on our side until this patient actually went to the operating room.
Thank you, Dr. Ruiz. Dr. Cowan, your turn.
Question.
So as everyone suspects, we did then proceed to the operating room. Okay. So we reopened his midline laparotomy, and we immediately encountered many filmy adhesions. They were throughout the abdomen. We performed an extensive lysis of adhesions. For this reason, perhaps for this reason, we did not encounter immediately any blood or any succus, but because of the lysis of adhesions, we had red, thin fluid throughout the abdomen as we worked. As I said, he had had a prior extended right colectomy with an anastomosis of the splenic flexure and a small bowel resection. We laboriously ran the small intestine from trites, found an old anastomosis, and then found the ileocolonic anastomosis. We did not find any injuries to the small bowel or the residual left colon. We did find a small non-bleeding liver laceration on the inferior surface of segment 4. And we found the bullet in the pelvis. It was loose in the peritoneum. And so we just scooped it out of the pelvis. He had previously, at his initial exop, had a Coker maneuver performed, or in his many courses. So we performed a redo Coker maneuver. When we were able to fully mobilize the duodenum, we identified 2 apertures, one anteriorly at the transition between D2 and D3, laterally, sort of at the lateral edge, and then posteriorly at the transition between D2 and D3, mid-lumen. We were able to mobilize enough to appreciate that the pancreatic head appeared uninjured and the medial duodenal wall, and we believed the ampulla were not injured or not involved. We examined the IVC, the aorta, the renal pelvis, and the portal structures, which were all uninjured.
Thank you, Dr. Cowan. Dr. Antrak, would you do something different?
Well, so in this case, you have the duodenal injury. So the issue is how to proceed. I don't know if you have a picture or how you can show us. It depends on how much injury there is. Is there a lot of necrosis around the bullet holes? But so Dr. Cowan's trying to say, no, there isn't a lot of necrosis.
So they were approximately 8 millimeters.
8 millimeters, right? You said that right. Yes, sure.
There was no bruising that we could appreciate. Of course, the planes were not clean, but it was a very interesting Coker maneuver for me because we had to basically lice adhesions for a period of time. So during the beginning of the cochlear remover, we didn't appreciate the adhesions until we mobilized it more, because the adhesions were, I don't want to say sealing it, because they weren't, because there was free fluid and there was air, but they were somewhat more hidden than I think they would have been had this been this man's first cochlear maneuver. So the edges were clean.
Right. So you have various.
Yeah, can I just make a very brief comment? Yes, it's Dr. Pust. The tricky part about this case, as she mentioned, is that the duodenum was mobilized prior to that. So you have to be very careful when you basically do a redo cochlear maneuver that you don't cause any injury to the vena cava, obviously, because you don't have this virgin planes anymore like you have on the first laparotomy, right? Because now you basically have adhesions between the duodenum and the vena cava posterior, and other loops of small bowel to the vena cava a little more inferior, because the right colon was gone. So you have to be very careful and take your time when you have a redo case like that you don't inadvertently cause other injuries, such as getting into the cava or something. I believe that typically the injuries are gunshot wounds to the duodenum, right? Often we find fairly large defects in the duodenum. But I believe because the velocity was already greatly reduced since the bullet traveled through the spine and caused a spine fracture, that the actual defects in the duodenum were very well, very small, 5 to 8 millimeters, no necrosis around it, and no major destruction of the duodenal tissue or compromise of the lumen. So I think that's important to mention, because obviously that contributes to how you're going to repair it and what you're going to do. So, but we will see.
Anyway, so what I was going to say is that first of all, it appears that the bullet went posteriorly to the spine, fractured the lamina, and then entered the abdomen and through the duodenum. So in terms of repair, I would do the simplest thing possible. If you can repair them primarily and transversely with no tension, I think that's reasonable. I would put a feeding tube in that you'd drain the stomach to reduce the tension. You could also put a retrograde, if you're worried, put a retrograde duodenostomy tube to decompress the duodenum. And then if it's more complex than that, there are other things you can do. You can put a serosal patch with a Roux-y limb, or do a Roux-y anastomosis to the area where the connect the two bullet holes, make one opening, drain it with a Roux-y limb with fresh bowel in that area under no tension. But I would do the simplest thing possible, which would be the first option, if the situation lends itself to that.
Thank you, Dr. Antrak. Dr. Hartman, do you have any comment?
No, I don't have too much. This is, I have seen many of these cases where they have so many adhesions that they don't leak into the abdomen. So it's kind of like, it's a blessing and a curse. They don't get peritonitis, but it makes your dissection extremely difficult. Again, without seeing the injury, it's very difficult. If I would do a primary repair and nothing else, very likely with 2 holes, probably do a pyloric exclusion with or without a gastrojejunostomy. But that would be kind of like the standard thing without seeing if it looks too good, maybe I just do a repair and get out. I don't think as Dr. Untrak mentioned, the serosal patch, they're very effective, but you might not have a way to do a serosal patch in this guy with all these surgeries.
This is Dr. Vittori. Can I ask Dr. Pust something? So how bad were the adhesions to the vena cava? And secondly, was there any hematoma around the vena cava? Did you find that there was a lot of hematoma there? In other words, what I'm driving at is that could it be possible that you could avoid complete cochlearization of the duodenum and look and explore the duodenum D2 and D3 without doing a complete cochlearization because of the extensive adhesions you talked about? So maybe this is one instance where you do less than perfect surgery, just enough for you to get to the lacerations, assess them, and do them in a very simplistic way. And this might even involve going through the anterior portion of the second D2, because we know the duodenal lacerations, if they're treated early and there is not a whole bunch of inflammation around it, can heal very nicely. And in fact, we recommend that most of the duodenal injuries can be repaired primarily in 1 or 2 layers and they heal fine. So what I'm driving at is that can you go approach these injuries, or can you explore the duodenum through an intact anterior wall in a convenient location so that you don't have to do this extensive mobilization of the Coker maneuver, which may be too hazardous, like you mentioned.
Yeah, it's an excellent question. So there was not a hematoma around it. The adhesions were there. They were not so hard that you say you can't do it safely. I didn't even think about doing a exploration of the posterior wall through the anterior wall. It's a very good point, because you already have an injury, you have an opening, may as well consider to enlarge it and examine the duodenum through the lumen when you have severe posterior adhesions, in order to avoid risk to cause an injury to the cava. It's a good point. What we saw the anterior injury first, and obviously since the trajectory is posterior from the spine, we were concerned about a posterior injury,
right?
And we felt like we should explore it and fix it. But you're right. Maybe just because the adhesions alone kind of isolate the injury, so that you may not even have to do it at all, right?
Exactly.
The question is, if you think retrospectively, if you have so many adhesions, maybe you didn't have to fix the duodenal injuries at all, because they're basically contained within the adhesions and probably don't leak. On the flip side, there's a trajectory or a connection to the spine, right? So you have a spine fracture, and obviously you're worried, what if a bile and pancreatic contrast juice leaks through the trajectory towards the spinal fracture, causing chronic osteomyelitis. So it's all good points, but we were able to safely mobilize the duodenum. I was pointing out it's not as easy as it is in the first case.
Yeah.
But yes, good idea. So to also consider to go through the injury.
My point is that sometimes you probably, as a experienced trauma surgeon, should opt for less than perfect surgery, less than perfect maneuvers, and try to do what's best for the patient. And I find that the intraluminal exploration of these lacerations is much more reliable than sometimes even looking at it from the outside, because you couldn't be sure that it's a through and through, transmural injury and not. So something to think about, for these unusual cases. So the pancreatic injury, if it is not extensive, if you don't think duct is involved, can just be treated by adequate drainage once you're mobilized. And in our experience, most of the duodenal injuries do not require serosal patches or a complete exclusion, etc. But most of them will heal fine if you get good repair and the duodenum is not devascularized. They all heal fine.
Thank you, Dr. Rivaturi. Thank you, Dr. Pust. Dr. Ginsberg, do you have any comment?
No, I got out of the OR a little bit late, so no comments.
Thank you.
How was your colostomy takedown? Was it good?
Yeah, I mean, it's always, they're always challenging cases. It went very, very well. But he's 17 and I decided to give him a colostomy, anastomosis. So it went pretty good.
Nice. Any other comments about approaches to repair before I go through what we did?
Dr. Epstein, any comment?
No, I agree. I would just try to fix it primarily, and sometimes you can fix the posterior injury through the anterior opening so that you don't have to mobilize extensively.
Thank you so much. Dr. Cowan, your turn.
Okay. So we did repair them primarily. I think it's really interesting to contemplate the risk balance, as everyone's discussing, of going through the anterior injury because it was so small. We had found both, and since they were favorably positioned, small, no hematoma that we could appreciate, no necrosis, we repaired them in 2 layers with PDS and silk. We then applied fibrin glue to both repairs, immobilized a mental flap and wrapped it around. And then we put a JP drain to either side, anterior and posterior, outside of those layers. And then the next, I think, topic of conversation is about drainage and feeding. We passed one of the 10 French flexible feeding tubes, had anesthesia pass it through his nose, gripped it in the stomach, and then worked it past our repair into the jejunum until we were satisfied with how distal it was. And then we put a decompressive nasogastric tube in his other nostril. And then we took a piece of jejunum about 40 centimeters distal to trites, tacked it to the abdominal wall and marked it with clips in case of difficulties later, so IR could place a percutaneous jejunostomy tube if needed. Feeding.
Okay.
Any comments?
Dr. Lenny, do you have any comment? Dr. Lenny? Dr. Ginsburg, do you have any comment?
Nope.
Okay. Dr. Antrak, do you have any comment?
Yes, so if you're asking the question, then I guess really the answer is relatively soon, at least to coat the gut. So I think most trauma surgeons say it's okay to start within 24 hours at small volumes. If you're worried about sepsis in the post-op period and translocation of bacteria, and you're going to be feeding distal to the injury. So I think early, within 24 to 36 hours, very, very low volumes, 10 mLs an hour or less, and then advance is tolerated, starting with half strength and then advancing as he tolerates.
Thank you, Dr. Antrak. Dr. Hockman, any comment?
I imagine that during the surgery, they did a complete lysis of adhesions to make sure there's no any distal possibility of distal obstruction. So I would start feeding as soon as possible. The duodenum is essentially a piece of a small bowel that is in a different location. So normally we start feeding within 24 hours. It was no pancreatic injury. I would start feeding early rather than late. But all depends on the situation. If the patient is having high NG tube output, it depends if I have questions about the repair. It looked like the repair went very well, so I would probably start very early.
Let me make a comment first. I didn't, I think, provide enough context. So he had the small bowel resection and the extended right. The small bowel leading up to the splenic flexure and anastomosis was dilated sufficiently, appearing chronically, that the radiologist, the resident at first misread it as being the right colon. So there was some dilatation that appeared chronic to that portion of bowel. So in that context, would that make your answer any different?
Thank you, Dr. Cowan.
I think you're muted, sir.
So yes, that would make it very differently, because the thing that would be worried the most is to have a distal bowel obstruction. And this patient might have a chronic bowel obstruction that he might manage to limp along, but suddenly after a major surgery like this becomes very evident. So I would, if I have any concern, I would probably give some gastrographing before attempting any tube feeds, make sure that it moves along. Again, without seeing the case, it's difficult, but that's a very serious consideration, the possibility of the distal bowel obstruction, because any leak in that area is really one of the worst type of leaks that you can have. Thank you.
Thank you, Dr. Hoffman. Dr. Epstein, any comment?
Yes. First of all, I love feeding tubes and I love the small feeding tubes, but if this feeding tube gets pulled out by the patient, or unfortunately sometimes by nursing care when moving him, so I'm not sure that that's the best option, because you can't put it back. So I probably would have put in a distal feeding tube. And if you did a good lysis of adhesions and you would know it, then the possibility of distal small bowel obstruction is lessened. And I think you were very fortunate to have momentum to put up in the duodenum.
We did tackle.
Can I make a comment, Mr. Dr. Pust? Yeah, so I agree with you that's why I like to have a backup, because that feeding jejunostomy, the nasal feeding tube sometimes gets pulled out and you lose access, and it's very important to have enteral access to feed the patient in case of he has a leak of the repair. So years ago, we used to do mandatory feeding jejunostomy, surgical feeding jejunostomies distal to the injury. We have moved away from it because you create an extra hole in the bowel, which can again cause problems. So what we do is, or what I do is at least, I just tack a loop of small bowel, proximal loop of small bowel against the abdominal wall on the left side, and we mark it with clips, with vascular clips. So the interventional radiologist has a very easy target sign to put in a percutaneous feeding jejunostomy in case of you lose the proximal access, the nasal access, and you have a leak and you need to feed the patient distally. So I think over the years, when I was a fellow 10, 12 years ago, we were very aggressive at doing pyloric exclusions and gastrojejunostomies and surgical feeding jejunostomies. And we have kind of moved away from it and learned that often, less is more, as Dr. Ivaturi already said. You try to do as little as possible, and every unnecessary anastomosis you didn't do is one less risk of leak. I think the concept here is really, do less, put good drains in, and have just the feeding access in case of you do have a leak, but you not necessarily need to do for every patient a pyloric exclusion and a gastrojejunostomy. I think those kind of things we should only do if we have more major destructive injuries. So often less is more.
Thank you, Dr. Epstein. Dr. Ivaturi, any comments?
Yeah, I agree with Dr. Pust. I think very good comments from him. I'm a big fan of nasoenteric tubes. I always put them in. Sometimes you win, sometimes you lose. Some of them come out, it's a pain, but most of them do stay in, and you can easily feed the patient from very early on, 24, 48 hours. And you could always do a gastrographic study to make sure that it's in the right place, make sure there is no distal obstruction, etc. So it allows you access to do some contrast studies, do early feeding more often than later feeding. So this patient, I would do exactly as you did. I want to compliment you on a wonderful piece of surgery there. You did exactly what I would do. Thank you.
Thank you, Dr. Ivaturi. And Dr. Roos?
Yes, thank you. It's a great case. Obviously, the type of repair that you do in this case depends on and this is for the younger trainees in the audience, depends on the condition of the patient, just going from wide drainage of the area if the patient is too sick and come back later when the patient gets stabilized, to a much bigger repair and reconstruction that is not a Whipple procedure, because I don't think there should be such a thing in trauma. Now, this distal feeding tube is still proximal to an anastomosis in the small bowel, so feedings are not going to be as fast as we would like to, and I would probably want to see some sort of GI function before I start feeding. Maybe starting low volume feedings early would be the ideal, but just wait until you full feed the patient after the patient has been fully resuscitated and the patient is doing better. A couple of practical things also for the younger trainees. When you put these distal nasojejunal tubes for duodenal injuries, I always suture them to the nose. I know this sounds rude and kind of savage, but I suture them. They last longer if you suture them to the nostril. And the other thing that I do is I ask the residents to get a KUB as soon as the patient lands in the ICU. So I have a baseline on how the tube looks like just as soon as it was placed. And in case sometimes there's question, the tube might have been pulled out a little bit. We don't really know. You have a picture that you can go back to and compare. So you'll know that your tube is in the proper position. That's it.
Thank you, Dr. Roos. Dr. Cowan, your turn.
Dr. Ruiz, you've made me regret not taking. We took an abdominal X-ray after we closed, actually, and I was very proud of how beautiful the nasojejunal tube curve was, but I forgot to get it, so I'm sorry about that. Any other comments before I go through what happened for him?
They do look beautiful when they're in the right place.
Yes,
Okay.
I was delighted with it because it had been very fiddly to pass through that last bit, like trites. So
Yeah,
anyway.
it's not easy to pass them, and where you want them to be, it's not easy. You would spend at least a couple of maybe 5-10 minutes extra, but that is
Fiddling.
worth it. That's worth it. Yeah.
I just
Yeah,
put
a
in
very
the,
brief comment.
I just put in the comment section what we use to prevent the feeding tube from coming out. We started using this a few years ago. I cannot remember a single tube coming out using this. It's a little bit less traumatic than suturing to the nose. And it gives you the peace of mind that you don't have to do anything extra. I completely agree that feeding jejunostomy in this case, if you don't have a hole in the bowel, don't make a hole. And we try to keep it as simple as possible. So I think if you're using this, you probably will not even tack the bowel to the abdominal wall, which is a point where the bowel can get twisted. And I have seen that happening too. So in order to keep it simple, we use this and with very good results. I don't know, my recommendation.
There is a whole technique called, putting a loop around the nasal septum. I don't know if any of you remember that, but with
So
another
this,
tube.
this is it, Dr. Ivaturi. This is kind of like a commercial device that does exactly that.
Yes.
We used that on him. And yeah, I forget what it's called as well, but I was on call last night, so I have word finding difficulties now. But I have seen them pulled out, even with
The bridle.
The bridle. That's it.
Bridle.
That's it. Dr.
Yeah.
Ruiz.
Thank you.
Yeah, just one quick comment about the early feeding. In general, I'm also a friend of early feeding, and Jane wanted to feed him very early. The one concern I had when you do very extensive lysis adhesions and you manipulate the entire small bowel, that you have a significant post-op ileus. And if you feed even low volume, let's say 20 milliliters per hour, and the proximal jejunum, and it doesn't move along because your patient has an ileus, then it will back up into the duodenum and potentially put you under your duodenal repair under distress, right? I mean, that's the reason why we put in a gastric tube to decompress the stomach and try to minimize how much goes into the duodenum. So, you have to be a little bit careful. That's Dr. Ruiz said earlier. I would start him feeding when you start to have some return of bowel function. I wouldn't go too aggressive on him for this concern, that you may not move the tube feeds along. And remember, if you give 20 milliliters per hour times 24 hours, that's 480 milliliters, so that's half a liter. And you do this for 2 days, you have a liter of tube feed sitting there if it doesn't move along. And I think that could compromise your duodenal repair.
Thank you, Doctor. Dr. Cowan, your turn.
Okay. So because, and everyone has stated, and obviously this is always the case, it's what the bowel looks like, it's what other concerns you have at the case. We did not actually start tube feeds until post-op day 7. We did start TPN early, given our concerns about post-op ileus. But we did start on post-op day 7, and he tolerated advancement very well. So we were able to stop TPN. On day 10, we started giving him clear liquids in addition to tube feeds. The nasogastric tube had come out a few days before. And then rapidly we were able to get him to regular diet, although he wasn't taking a full diet. So we kept tube feed cycled at night for a period of time, and were able to stop them on post day 17 completely. But he was on a regular diet basically from day 11. For context for the spine, they did no decompression. He had, they felt concerns about an unstable fracture, given that it actually passed through the facets and somewhat through the canal. So he was actually stabilized percutaneously on, everyone's pictures in the way of the post-injury day. And he was kept in a TLSO brace when upright. Subsequent evaluations of his neurologic function distally, he actually struggled very hard with the neuropathic pain from this injury. And we had to work with the acute pain team to manage him. But he actually had deficits in sensation very distally, but he's now still in rehab and he has recovered. He's recovering some proximal leg. He can fire his quads now, although not really bend the knee. So he's having some amount of recovery. We kept the drains in for a long period of time. We actually didn't have any concerning character of drains for a leak, but it was somewhat bloody for a sustained period of time. So we left them. Less of a concern for a leak, but they were removed. And then he is at our rehab facility at Jackson, or adjacent to Jackson, and is doing very well.
Thank you, Dr. Cowan. Excellent presentation. So would any panelists like to make any comment?
Yes, I would like to say something. It's an excellent case, very well managed, excellent presentation. And for all the juniors in the conference, I think there is a lot of practical points that were made, which I hope you listen to. And I hope there will be a written summary or recording of this particular case, because there is an enormous amount of practical points that were made. And that's very, very important for the practicing surgeons, especially the junior ones. So thank you for that.
Thank you, doctor. Any other panelists would like to comment? Dr. Antrak, any comment?
Yes, so yeah, I agree. Very, very well done case. Just a question: did the neurosurgeons say whether they would have done anything differently had they been called early on? Would that have made a difference? I mean, that's the only thing I would have considered in a stable patient. Maybe, you know, running the case by them early on, showing them the films, making sure that they didn't feel that they need to do a decompression or something else to try and minimize the neurologic damage.
So they were actually consulted before we went to the OR, and as Dr. Pust had alluded to earlier, he came in at around 2, and we had the neurologic deficits right away, and this CAT scan for a number of hours before he went to the OR. So they actually had viewed the CAT scan and examined the patient before we went. And at the time, they said no acute intervention, and it was only later, after he was stabilized and we knew what was going on in his abdomen, et cetera, he'd undergone the case, that they went back and forth and said, we're going to stabilize this so he doesn't have any further damage.
Okay, so in view of that, then perfect case, perfectly done.
Dr. Pust's work, I helped.
Dr. Epstein, any comment? Any final comment?
No, great case. Something I wouldn't have wanted to start at 3 in the morning.
Thank you, Dr. Epstein. Dr. Lenin, any final comment?
This is a trivia. Dr. Lenin actually was the one who performed his initial case 10 years ago.
Dr. Ivaturi, any comment?
No, thank you. I think it's a great case.
Dr. Ruiz, any comment?
Thank you. Great case. This is the most complex small bowel pathology that we get in trauma, when it involves both the duodenum and other parts of the intestine. So most of the principles we have to modify it to account for both. And then the last thing is be sure that the patient is on antibiotics, because there was a direct tract in between the and the GI tract. So this patient will have to be covered with prophylactic antibiotics to prevent some sort of neurological infection down the road.
He was. I'm sorry, I neglected to mention that.
Thank you, Dr. Ruiz. Any other panelists, would you like to make any final comment?
I think Dr. Hodgman had a comment. I think you had raised your hand.
I was having a concern about the spine, like Dr. Untrach. I'm at home. I cannot ask any of the neurosurgeons who work here, but here they always want to get an MRI, which obviously you cannot do in this patient because you have too many bullet fragments. But in a case like this, where you have this asymmetrical, you have motor deficits with neuro intact, the concern is an epidural hematoma, so they would probably request a CT myelogram to make sure that nothing needed to be decompressed. And particularly because they did that.
Did get one postoperatively.
Oh,
Yes.
okay, okay, okay.
Since we were focused on the duodenum, I sort of scuttled a little bit of that, but he did get one postoperatively. I think it was not immediately postoperatively. It was a couple of days afterwards, but before they did the fixation. And we managed to end on time too. Yay.
So thank you so much, Dr. Pust, Dr. Cowan, for the incredible work, fast work, but amazing. Thank you for support us today. And congratulations. Excellent presentation.
Thank you. Everyone have a good day.
Bye-bye.
Thank you all the panelists too. Amazing.
Bye. Thank you, everybody.
Thank you so much.
Thank you.
Bye.
Thank you.